I think that first one of the conclusions was that these side effects we are talking about are relatively common. They probably afflict more than 50% of the patient, but they are rarely severe. They are usually quite mild, and sometimes they even do not require very aggressive treatment. The point is that in some cases, in some patients, they might be life-threatening. And those are the situations you need to detect as soon as possible and treat as soon as possible. And that's a difficulty because there are no real biomarkers which predicts the severity of these complications. The treatment, the universal treatment is immunosuppression by corticosteroids. If it doesn't work, you have to resort to more potent immunosuppression with other more potent drugs than corticosteroids. So that's really the basis, and the other, of course, is to discontinue the offending drug and just restore treatment only in mild cases of side effects, and certainly not if a severe side effect had occurred. You have to separate the different scenarios. Of course, combining two different classes of checkpoint inhibitors become a common practice. One conclusion from our symposium was that if you do that, you increase the rate, the incidence, and the severity of the side effects. So that's one point. You don't create new side effects, but you increase the rate and the severity of the side effects we were discussing already. Now, if you combine that with targeted therapy or with classical chemotherapy, you cumulate the specific toxicities of checkpoint inhibitors with the specific toxicities of targeted therapies or chemotherapies, and that can become quite tricky.